issues. We are, yeah, now we are on. So we'll request Nitya sir to start. You are mute, sir.
Good evening, all these respected doctors and other dignitaries who are present in this forum on this webinar, CME session on pediatric leukodystrophies. So I do welcome our Paulomi madam, who will be introducing all these panelists and the speakers here for this wonderful session. I am handing over the session to Madam Paulomi. Over to you, ma'am.
Thank you so much. Very good evening to all the respected dignitaries and participants. I feel extremely delighted to introduce and start this session. So at the outset, I would like to invite and introduce Dr. Anjan Bhattacharya, who is known very well-known neurodevelopmental pediatrician, and he has established India's first CDC in the corporate healthcare setup, the WHO International Global Expert on ICF in Child Disability, RCPCH UK Examiner for DCH UK and MRCPCH UK examinations, Board of Examinations, Royal College of Paediatrics and Child Health UK, ex-honorary affiliate tutor, IPPC DCH, Sydney University, Australia, Pioneer Award recipient, East Zone IAP, Bharat Jyoti Awards, IIFS, DNB Center Inspector for NBE, New Delhi, and ex-head academics, Apollo Gleneagles Children's Center. And last year, he was awarded as the top 10 doctors by India Today, who is working in the super specialty sector. I welcome Dr. Anjan Bhattacharya. Sir, I request you to share a few words about today's session. Then I'm going to introduce our respected speakers.
Thank you, Paulomi. Thanks for nice introduction. At the outset, there is a disclaimer that, there are 3 doctors. 2 of them are pediatric neurologists who will be talking today. I'm a developmental pediatrician and not a pediatric neurologist. We are talking about a pediatric neurological subject today. What is the background of this? So first of all, thanks Shield Health for organizing this, because after some time we are again coming back to this. This is something that used to run once every month, and that endeavor was thanks to Joel Chakraborty, who was our pediatric physiotherapist. So we ran it for 5 years, then gradually we got busy into other things, and then this kind of dissipated a bit. That is why we are only doing this when we find something of relevance. So how did we find this topic, which is a bizarre name to healthcare professionals who are not doctors, to understand about this? So the background is that, Dr. Arijit Chattopadhyay, whom you all know and you will get introduced to him, and Dr. Jashodhara Chaudhary is already has joined. So the background is, in our Friday grand round meeting, Dr. Arijit Chattopadhyay has presented one presentation on very similar topic, and I thought, oof, I wish the members of the multidisciplinary team had an understanding of this, because there are pictures and videos and symptoms described to which they can associate. So these symptoms are not very easy to decipher or discriminate when the same symptom is presenting for about nth number of possible diseases and disorders. The problem in India that we have seen in the past is that it's all clubbed under either cerebral palsy or seizure disorder, and that's it. The members of our team who are with us and the students of our postgraduate diploma course in early intervention, the diploma course from MACOUT, the 3 who have passed and the 7 who have already joined, they must have seen a child with a neurological condition right now, which is tuberous sclerosis, and the child has been given a life-limiting condition, a prognosis, because the child is having seizures a lot and has got hemihypertrophy, and was absolutely developmentally stunted. Parents have been to every big hospital and every big name in the country. Finally, they have come back to Kolkata. They are not Bengalis, but they are from Kolkata, but they have traveled around the country and received very good medical care, all of which was not giving them satisfaction. So they came to us, and then Dr. Arijit Chattopadhyay has referred the child also to us, saying that, I will be looking after the neurological condition, but I think the developmental aspect needs to be expertly handled. Now, few months down the line, our participants who have actually seen what the parents are saying now, how the child is blooming, and how the parents have got some hope, although constantly we are talking to them with a life limiting situation. They know this, they are not going to have the child forever. Despite of that, how happy they are, how happy the child is. Now, this interest of having Dr. Arijit Chattopadhyay talk about this, the neurological part about it, got heightened when I also attended into another panel on early intervention, which Dr. Jasodhara has kindly organized. She was the organizing secretary. This was the third annual conference, national conference for the Pediatric Neurology Society. Dr. Jashodhara has presented something on this particular topic with some videos. And I then thought that these videos our multidisciplinary professionals really need to see with the background of basically their scientific understanding about it. So without much ado, if we now get Dr. Jashodhara to talk about this topic, and then Dr. Arijit Chattopadhyay will eventually come and join and make his presentation. I think we will have a nice discussion after that. Dr. Jashodhara will have to leave after some time. We are all very busy. I've been somewhere else. Some of you know that I run from there. She's going to run into something else. Miles to go before any of us can stop. So this must also happen to the multi-professional team members to introduce her. Again, no better than the head of the Poulomi Niyogi consultancy, Poulomi Niyogi herself. Over to you, Poulomi.
Thank you so much, sir. We welcome Dr. Jashodhara Choudhury, who is a renowned pediatric neurologist, MD Pediatrics, MRCP CH UK, DM Neurology, Mini Movement Disorder Fellowship from Nebraska, USA. She's the author of 30 publications in national and international journals, currently Assistant Professor of Neuromedicine, NRS Medical College and Hospital and Institute of Child Health as visiting faculty member, National Task Force member of SMA and Wilson disease. It's a great delight to host you for today's evening, madam. We look forward to listen to you. The session is all yours. Thank you.
Thank you, sir. At the outset, I'd like to thank you all for this invitation, and I'm much honored. I think I am not actually sure about what to say regarding this because this is a very vast topic. So I have decided, sir, do stop me whenever you feel that it is going too much or too much into the neurological details. But I'd like to show the different types of leukodystrophies. And as you, sir, rightly mentioned, you are doing a great work as a multidisciplinary team. It is not always about neurology. It is not always about the academics or the theory part or understanding the disease. It is always about the patient outcome, what we are being able to give the patient. Because leukodystrophy is such a condition that at the outset we have to tell the parents that the diagnosis is dismal. We cannot do much. But however, how long the child lives, we have to ensure that so that the time is more or less happy so that the child gains something. That is where this importance of multidisciplinary team and whatever great work you are doing comes in. And the work in a progressive developmental aspect is always important for this child who are having neurological deficits. So I will, where's this? I'll start sharing my screen. Please let me know whether it is visible or not.
Yeah, it's visible. Make it full screen.
Okay.
Yeah, perfect.
Okay, I think it's okay right now, right? So I'll just go on the leukodystrophy and its approach. And please let me know when the time is nearing up. So just let me know. So there will be some introduction. What is it actually? The anatomical and pathological aspect, which I'll just touch upon for the students, and the classification, how to approach, and few individual diseases. So leukodystrophies is actually an inheritable disease, and it is mostly progressive. So whenever we diagnose, we just have to tell the parents, whatever you are seeing the child as now, the child will progress further. The child will deteriorate further, because that is almost a thumb rule in case of a diagnosis of a leukodystrophy. So it is the involvement of the central nervous system, white matter. Because we know we have the two matters, the white matter and the gray matter. Leukodystrophy mostly involves the white matter. The first report was done by Pelagius and Marsbecker. We know there's a disease called Pelagius-Marsbecker disease, that on a familial occurrence of a chronic progressive diffuse sclerosis. And that was not actually multiple sclerosis. And so that was the first onset. And the term leukodystrophy was used for the first time in the early 1920s, the 1928, in the context of a metachromatic leukodystrophy. That is now a very well-known entity, of course. That was a known white matter degeneration. Now, another term is commonly used and rather was used, like leukoencephalopathy. That diffusely involves all the white matter diseases. But nowadays, we do not encourage the use of that term. So, we have two matters. See the gray matter. This is a T2 MRI image. The gray matter and the white matter. So, the gray matter is the black portion and this is the white matter. And white matter, how does it help? It is actually bundles of nerve fibers, and that connects very vital areas of the gray matter one to another. So when you see leukodystrophy, the white matter is affected, the connection between vital areas of the brain get lost. And when this parts of the brain is degenerated, so these important connections get lost and hence the diseases manifest. And you know why? The white matter is composed of myelinated axons, glial cells, and different OPCs like oligocyte. These things are actually not needed. These are very basic science. However, we must know that this white matter, this all part degenerates in the leukodystrophies, and hence the diseases get manifested. So the thing is that the difference may not be always very classical. The difference between classical and the inherited and the acquired. And many of the times as doctors, we are in dilemma, whether especially in older children, whether this is inherited leukodystrophy or acquired leukodystrophy, because the treatment varies a lot. So if we classify the white matter diseases, there are mainly 4 kinds of characteristics. Hypomyelitis, that is, there is lack of myelin deposition. Demyelinating, loss of previously deposited myelin. Dysmyelinating, that is, abnormal myelin is getting deposited, and myelinolytic, that is, myelin vacuolization is going on. So this is the different kind of white matter diseases. So the myelin disorders, again, another classification is like myelin disorders, which I just now mentioned. Then there is the astrocytopathies, leukoaxonopathies, microgliopathies, and the leukovasculopathies. So we are not going into this details. We all must know that myelin is the covering of a single nerve fiber. And if this gets hampered due to any reason, be it there is not enough production, be there may be abnormal production, be the integrity of that myelin is disrupted, we get leukodystrophy. So the few diseases like the hypomyelination, where the myelin formation is inadequate, is the Pelagius-Marsbecker disease. When there is abnormal myelination, then there is metachromatic leukodystrophy that we call as MLD, Krabbe's disease, X-linked adrenoleukodystrophy. When there is myelinolytic lesion, there may be different mitochondrial diseases causing leukoencephalopathy, amino acid metabolism disorders, and Canavan's disease. And the astrocytopathies, Alexander disease, the child typically comes with a large head, vanishing white matter disease. The leukoaxonopathies, the LVSL group, which involves the spinal cord also, and the microgliopathies, which is with the diffuse leukoencephalopathy with spheroids. So the approach to leukodystrophies is on two pillars. One is a clinical and another is a radiological. So we see the important things that we have to detect is infancy. Infancy, one is a delayed developmental milestones. They may present with delayed developmental milestones. And again, another thing, they may present with failure to thrive, they may present with seizures. In late adolescence, adulthood, they may present with psychiatric behavioral abnormalities, cognitive or intellectual decline, and other things like spasticity, ataxia, peripheral neuropathy. These things may be associated. So these are the few diseases that present with these classical pictures. So we see some psychiatric symptoms, plus cognitive or intellectual decline, and there is spasticity in the limbs. Then associated with these things, if there are eye findings, like there are nystagmus, tremor, choreoathetoid movement that we call the extrapyramidal affection, we see that this is Pelizaeus-Merzbacher disease. If these things are associated with some peripheral neuropathy, optic atrophy, seizures, then that will be metachromatic leukodystrophy. Again, associated with sphincter dysfunction, the child is not able to hold urine. There will, if there is adolescence is not coming, peripheral neuropathy, then X-linked adrenal leukodystrophy may be the thing. Then if associated with myoclonus, nystagmus, retinal degeneration, it may be Krabs disease. And again, if it is major deterioration following a minor febrile illness associated with epilepsy, ataxia, it may be vanishing white matter disease. So you see there are numerous such diseases, which is very difficult to remember. But as neurologists, we remember the spectrum. For example, if there is history of recurrent diarrhea, a child comes with neurodevelopmental disorder with recurrent diarrhea. On examination, you find the child is ataxic, the child has bulbar symptoms. There is tendon xanthoma, like in the Achilles tendon, there is xanthomatous findings. You see, that is a cerebrotendinous xanthomatosis. And if there is personality changes, difficulties, Parkinsonism, which is actually rare in a young child. So we see that it is hereditary diffuse leukoencephalopathy with axonal spheroids. I don't think it's not possible for anyone to remember all these names, but we think that there are some clues or symptoms that we should look in the patients, especially in an older adolescent. If we find that he is having increased difficulty in walking, developing spasticity with peripheral neuropathy, then we have to think that it is adult polyglucosan body disease. And bulbar dysfunction and palatal myoclonus, adult onset Alexander disease. Then autonomic dysfunction, if there is there, it may be a dominant adult onset autosomal dominant leukodystrophy. Migraine and stroke, if in an older adolescent, it may be CADASIL. Then if a girl child presents with amenorrhea and cognitive decline, we have to think of vanishing white matter disease. And macrocephaly is associated typically with three diseases like Alexander disease, Canavan disease, megalencephaly, leukoencephalopathy with subcortical cysts. So the radiological approach: frontal predominance, parieto-occipital predominance, and periventricular predominance. So the frontal in the MRI. So radiological approach means we have to do an MRI. After the clinical clues, we go for an MRI, and then we find out what are the kind of diseases we need to see. So the frontally, if this thing is frontally, this is the frontal part of the MRI. This is the parieto-occipital part of the MRI, the backward portion. And this is the periventricular part of these are the ventricles and the periventricular part of the MRI. So in the frontal part, there is a frontal variant of MLD. This is the Alexander disease. In the metachromatic leukodystrophy also, frontal predominant lesion. The frontal lesions are more predominant, and this is called a butterfly pattern. You see, it's like the wings of butterfly. And now comes the posterior predominant. The backward portion, this is the parieto-occipital area of the MRI, is more prominent white matter lesions. So it is showing symmetrical confluent dysmyelination. And this is a classical picture of adrenal leukodystrophy. Again, Krabs disease. what we see is a posterior predominant white matter changes and involvement of the splenium. So you see this part is called the splenium. There is some white matter changes and posterior predominant. Perhaps this is again posterior predominant white matter changes. So again, this one is a T2-weighted MRI image that shows that confluent areas of periventricular white matter changes. This is again I showed a metachromatic leukodystrophy where there is pairing of U fibers. We call this U fibers and this has paired, and there is lack of enhancement. There is no contrast enhancement. So again, this is a megalencephalic leukoencephalopathy with subcortical cysts. So you see the cysts. This is full of multiple cysts, and whenever we see the MRI plate, we know that this is this disease. And this is a CADASIL. Here, what happens? It is actually seen in the adult population, but adolescents may have this. There's a genetic disease. And what happens in this is that a patient presents with migraine-like headaches, may present with young onset stroke also, may present with forgetfulness, episodic memory loss. When we do the MRI, we see this kind of white matter lesions and temporal lobe involvement is there. And this is a genetic disorder. So again, this is a Canavan's disease and glutaric aciduria that is very commonly seen in children. There is the atrophy of the bilateral sylvian fissures, and we neurologists, whenever we see the MRI, we can understand this is this disease. And the child classically presents with a worsening during a febrile episode. There may be seizures, there may be downhill, there may be cognitive decline, and the child may have glutaric aciduria. So this one is the indentate nucleus. This is very important. So this is another glutaric aciduria, L2 form of glutaric aciduria. There is a classical involvement of dentate nucleus. So the posterior fossa predominance, when we go to the neurologist and when we see the place, we divide like this: the anterior dominant and the posterior dominant lesions and the brainstem lesions. So the posterior dominant and the brainstem lesions are the CTX or the cerebrotendinous xanthomatosis, Alexander disease, LBSL, and adult autosomal dominant leukodystrophy and adult polyglucose and bolidosis. These two are named adult, but actually these are seen in adolescent children also. So this is a classical picture of cerebrotendinous xanthomatosis where we see a cerebellar white matter changes. This is the posterior part of the brainstem where we are seeing this white matter changes. So going by, I'm not going into the details, but when we suspect a Pelizaeus-Merzbacher disease, we see a child will be coming with some developmental delay. The very important thing here to note will be there will be abnormal eye movements. There will be abnormal nystagmus. Then there will be ataxia. Ataxia means the child will have a gait unsteadiness. Whenever the child walks, goes this way or that way. There will be dystonia. That means there will be some tonic posturing of the child. The child may show some hand posturing. Dysarthria. The child may have progressive difficulty in speech and progressive spasticity. This may be severe infantile onset. It may start from the 1 year, first year of life, may start from childhood, and may present with spastic paraparesis in adult life also. It is mostly due to missense mutation in PLP1 gene. And the 20% of individuals with clinical and radiological PMD do not have mutation. And these are called PMD-like disease. And we have seen these patients who have PMD-like disease. And the clinical feature is like whenever a child comes with nystagmus, we need a close follow-up. And mostly this child go to the ophthalmologist, but I think they should visit the neurologist also because we need to follow up this children. And again, in case of adults, the Pelizaeus-Merzbacher disease presents with spastic paraplegia and is mistaken with dorsal myelitis and forms of multiple sclerosis. So radiological features we have mentioned. And we know this is posterior fossa, the more affected. And we see that this is the medulla part and there are hyperintensities. And also bilateral symmetrical hyperintensities and diffuse white matter changes and cortical atrophy. And treatment still now is in a rudimentary stage, but transplantation of human neural precursor cells in recent trials have shown to have a minor impact. But again, it is all supportive care regarding the management till now. Then PM-like disease, Pelizaeus-Merzbacher-like disease, which we have seen, other mutations may be responsible. Presence in infancy, childhood up to 15 years from case reports we have seen, and infancy with nystagmus as we see, and the treatment and radiology similar. Now comes the important things that we see in our clinical practice often. The metachromatic leukodystrophy, Kraft disease, and X-linked adrenoleukodystrophy. So it is actually not that uncommon. 1 in every 40,000 live births. It's due to our aryl sulfatase A deficiency, R gene mutation. Then it may be classified as this late infantile, juvenile, and adult onset types based on the age of onset. Now, what happens is that there is some sulfatide excess with cytotoxic effect of lysosulfatide, and that contributes to the oligodendrocyte and neuronal death. So these are the subtypes. I'm not going into the details. What happens is the infantile form that child presents with irritability, regression, peripheral neuropathy. The child falls down. There is difficulty in swallowing. There are seizures. And there is early death. Then there's a juvenile form in the early adolescent from 4 to 16 years who presents with ataxia, may present with spasticity, difficulty in vision, optic atrophy, peripheral neuropathy, and the adult form that presents with psychiatric disturbances, and they go to the psychiatrist rather than the neurologist. And after visiting many psychiatrists, then they may come to the neurologist after an initial MRI. So in the radiology, I've already shown there are frontal predominance with sparing of U fibers, and the corpus callosum is involved early, because as neurologists, we have to see the few typical patterns of involvement so that we can differentiate from the other disorders. And this is one of the classical picture of metachromatic leukodystrophy. These are the U fibers, these are the U fibers, which are classically spare. And if we do a contrast enhancement, we will see no contrast enhancement, which is classically again spare. And this is the famous tigroid pattern, as these are the numerous linear tubular stripes that we see in the MRI. And there are sometimes a punctate pattern is seen, that is called the leopard skin sign. So diagnostic test is still the molecular genetics and the elevated urine excretion of sulfatides, which is an indirect test. And the treatment is a treatment of manifestation till now, genetic counseling, and carrier testing of at-risk family members, and counseling. And stem cell replacement transplant is therapy for primary CNS manifestation diseases. And in the best, sometimes good results are obtained in patients where it is done earlier. However, it is not recommended for individuals with symptomatic late infantile MLD. It is for juvenile MLD onwards. Enzyme replacement therapy is not effective because the enzyme is not able to cross the blood-brain barrier. Gene therapy is a promising option and it is under development. And I think it has been applied recently. We saw news on LinkedIn in the Great Ormond Street Children's Hospital. So again, ALD that we see also commonly in our practice, that is impaired metabolism of very long chain fatty acids, and that results in due to the genetic defect of ABCD1 gene. It's a paroxysmal disorder that affects the white matter, and it is the genu and splenium of corpus callosum where it strikes the earliest and the most severity. With the most severity, clinical phenotypes are different. It's the male XALD. The types are only Addison's disease, that is presence with dyselectrolytemia, no neurological impairments. Then there is the central ALD that presents with neurological impairment, and adrenomyeloneuropathy that presents with cord involvement, that is spasticity, difficulty in gaze, difficulty in bladder functions, but no brain involvement or no cognitive decline. Then there are women with X-linked ALD, it has been found, and there are also asymptomatic patients and pre-symptomatic patients, and therapies works best for the pre-symptomatic patients, because we have seen many siblings of the symptomatic children, and therapy is the best for them. So there are Addison only. These are presenting symptoms in boys and men. They present with Addisonian crisis also, and it is the consider X-linked ALD in an adult male presenting with Addison's disease in any boy. This is very important, and we have to think. Like there is darkening of skin, there is insufficient glucocorticoid function. We have to think of this condition. And then there is a childhood, adolescent, adult onset. I'm not going into the details. This is the decline of school performance. This is misdiagnosed at ADHD because they have visuospatial and visuomotor attention and reasoning deficits. There is executive dysfunction. I told there's a frontal variant also. There's the executive dysfunction. You know, the frontal lobe that does that, the orbitofrontal cortex, the dorsolateral premotor cortex. So these children have their executive dysfunction, attention span reduces, and they are misdiagnosed as at the age of 3 years as ADHD, many often. But we have to look at the other symptoms and signs, and if this is the hidden disease, we have to treat it differently. And in the adolescent things, the symptom onset is slower. They present with dementia, cognitive decline, ataxia, seizures, psychiatric disturbances. These are the presentations. And adrenomyeloneuropathy, that is the spinal cord and the peripheral nerve disorder, presents with paraparesis and may be misdiagnosed as multiple sclerosis or HSP. So the women with X-linked ALD are the most neglected people. 20% of female that carriers, they develop symptoms usually in the 4th decade. And the funny thing is that when they develop symptoms in the 4th decade, they are diagnosed as fibromyalgia, that is a somatoform or psychiatric disturbance, and they are mostly not treated. And the family members are not often screened. So it's very important to know that this disease entity exists. So we see that we are not going into the details because this adrenoleukodystrophy, the radiology only for us, the neurologists, has many patterns and many different types. So I'm not going into the details, but I'm showing some pictures. So this shows that the confluent demyelination of the peritrigonal, this is called the peritrigonal white matter, and this part is the corpus callosum. I told that the corpus callosum is one of the first and the foremost points to get hit. Again, this one shows that the splenium of the corpus callosum is being affected. So this is the area where the peritrigonal areas. This is the T1 weighted image. This appears hypointense. And so see, there is the enhancement pattern. Remember in metachromatic leukodystrophy, I showed that there is no enhancement. Here there is a classical enhancement of the enhancement pattern, typical of the sides of the sites that showing this enhancement pattern. Again, we see there's a involvement of this internal capsule. This part is the internal capsule. Then coming downwards to the posterior fossa, these are the pyramidal tracts, the descending tracts, these are involved. Then this is the cerebellar deep white matter. This is involved. And again, this shows enhancement. Then this is the atypical ALD. I show that the frontal variant is there that looks like metachromatic leukodystrophy, but if a contrast is there, this will enhance. That one is the difference with the metachromatic leukodystrophy. So we have to do the genetics, we have to do the mutation analysis, genetic counseling should be done. Management is still the stem cell replacement. And then other things may be given, like the lovastatin may be given to lower the VLCFA, but it does not show much benefit. Antioxidants is given, that is what we give because stem cell transplant is not possible. And this thing, lentiviral based gene therapy is now coming, and the siblings MRI brain is recommended and ACTH monitoring is recommended for the siblings. And treatment, dietary restriction of VLCFA, and this Lorenzo's oil that is available in Mumbai, that can be given usually in pre-symptomatic patients. It works well and it normalizes the VLCFA levels. But if there is neurological already damage done, it is not very effective, then the stem cell replacement and antioxidants that we have to give. Now the crabs, there is a mutation of the GALC gene. I'm not going into the details. It is very rare disease. Again, it is divided into 3 parts: the infantile, the juvenile, and the adult. The infantile presents with the developmental arrest after a slight fever. There is myoclonus. Here, this is special. Nystagmus and optic atrophy. And in the juvenile patients, there is progressive symptoms are there. And in adults, present with progressive cognitive decline. And here I'm again, there are types, and the important thing is cerebellum and pyramidal tract early involvement is there. So here the thing is that there are posterior predominant white matter changes, posterior side predominant, and involvement of the splenium of corpus callosum. CT shows there will maybe hyperdense areas in the thalami. So note that there will be thalamic. So Krabs disease, we have to remember that gray matter involvement is there, and thalamus is classically involvement, which is not seen in adrenoleukodystrophy, but both are having posterior predominant involvement. The diagnosis is nowadays genetics, and therapies is again stem cell replacement therapy. Other therapies like ERT gene therapies, still now we are not, it is in pipeline. Then the Canavan disease, the child who presents with a large head, the mean survival time is 3 years. It is present with hypotonia, spasticity, cortical blindness. The MRI looks very dismal. There is megalencephalic appearance. There is atrophy, the diffuse white matter involvement, and the whole prognosis is very dismal. And there is restricted diffusion in white matter in the acute form of the disease. And MRS is also important in these patients. Then comes the Alexander disease, that is the glial fibrillary acid protein gene affection. And here also there are different forms. I'm not going into details. Again, there will be a large head in a child who is present with severe developmental delay with seizures. And this patient also have early death. And the disease begins in the frontal region of the brain and extends posteriorly. So you see that these are the classical pictures of Alexander's disease, where the frontal predominance is there. So you see there is symmetrical demyelination. A kind of garlands can be seen along the lateral ventricles. You see, this is the garland sign appearance. And in the juvenile onset, in the adolescent, there are spinal cord involvement. You see the white matter changes in the spinal cord, so they may cause spasticity. So management again is a surveillance genetics. There is no definite management. Till the child leaves, we can pay attention to the nutritional status, swallow therapy, and to see for early signs of scoliosis. And another important thing is a Van der Nub disease. This is a megalencephalic leukoencephalopathy with subcortical cysts. It's again due to genetic mutations. And again, there are 2 phenotypes, the classic and the improving phenotype. So they show that early macrocephaly, gross motor developmental delay, status epilepticus, ataxia, spasticity. And there is another phenotype that shows that delayed development followed by a slightly improving clinical course. And this is very important for the multidisciplinary team, because this phenotype shows that they have some symptoms of autism. And then there is there's a large head. Some children may later become normocephalic. Some intellectual disability there is autistic features, there is some regression followed by a plateau or slight improvement phase. So this phenomenon is a mutation of MLC2B, and this mimic autism with epilepsy. They may have epilepsy later in life. So we have to know this part. And when we do the MRI, we see that there is T2 weighted hyperintensity in the high white matter like this, and there are cysts. There may be multiple cysts or solitary cysts. You see, there are cysts. This is the black area. That means there is no brain matter, and this is filled by the CSF matter, the white matter, the fluid. So these are the cysts, necrotic areas. So elevated levels of glycine has been reported in CSF. Again, a vanishing white matter disease that is very closely related to these 2 diseases. Often one is used in the name of another, but actually that is not should be used, because that is this is actually different. This mutation is in the eukaryotic initiation factor 2B. It's a different thing. And here again, there are two presentations. Then one occurs in 2 to 6 years, again with epilepsy after rapid deterioration following a minor febrile illness. In females, there are ovarian dysgenesis. This may happen. I'm going a bit fast because I think I am overshooting time also. So this is actually so that's why it's called ovario-leucodystrophy. So whenever we find a female child after a short febrile period presenting with acute deterioration, acute cognitive decline with seizures, we have to look for the ovarian status also. We have to see whether there is any extra neurological involvement also. That may be the presentation of vanishing white matter disease. And these are T2 hyperintensities with cystic changes. So you see, this is those look similar, but there are some changes. The cerebral white matter, see, this has been replaced by fluid. So there is no brain matter. The white matter gradually looks as this is the white matter. This is the T2 image, clear image that looks like the CSF. And the corpus callosum that has gradually vanished. These are the images. There is no specific treatment. So avoidance of stress situations like fever and these things have been shown to be helpful. So these are the other diseases. I'm not going to develop the hereditary diffuse leukoencephalopathy that presents with the spinal cord-like manifestations. The symptomatic patients present with spastic paraparesis, and we see the lesions in the pyramidal tracts. So again, this one is a CADASIL that is seen in late adolescence, usually in the 4th decade, not in children. Young adulthood, severe migraine, recurrent migraine, not responding to treatment. We have to think that if there is something wrong, if there is family history, we have to suspect whether this child or adolescent is having this CADASIL, and there may be mood disturbance, maybe seizures, and a moody child maybe with migraine complaint, may be neglected, and then the child may land up with a stroke, and the child was having CADASIL all along. So the typical features are temporal lobe involvement, white matter involvement, and diffuse white matter involvement. So again, this is a CADASIL MRI. There is no specific treatment, but there is the treatment for the symptoms. So you see this ichthyosis, a child presenting with ichthyosis, in the neurological symptoms presenting with spastic diplegia, and there is some retinal examination shows some finding, and then there is the severe signal intensity in the periventricular white matter, and there is some changes in the occipital trigons, these areas. These are the unmyelinated subcortical association. This is the cerebrotendinosis xanthomatosis. This is a rare metabolic disorder where the child presents with this childhood history of recurrent diarrhea, failure to thrive, tendon xanthemata, especially in the Achilles tendon, osteoporosis, respiratory. Then the MRI features are often this deep white periventricular white matter changes. Flipping the slides. So I'd like to say that this is a very vast thing, and it is not possible to cover because it's very difficult to remember for us also. But what we try to remember is the basic clinical features. And for the multidisciplinary team, I'd like to say that few diseases like vanishing white matter diseases, the subtypes, then in an adolescent, metachromatic leukodystrophy, this presents with features of psychiatric disturbances, features similar to autism and ADHD, and they may have underlying this kind of leukodystrophies. So it's very important from your part to understand the basics of this disease, that there may be overlaps, and from our part it is important to know that we should have a multidisciplinary team behind the betterment of this child. So the first and foremost is understanding the disease so that the parents get a diagnosis and the siblings get checked. If the family is having such a diagnosis, the siblings get changed, because nowadays many therapies are getting approved. So in a pre-symptomatic state, if we can start the therapy, that it may change the life of a child. And also, if we diagnose the disease, if we do intensive therapies, then the whatever the life period the child is having, we can have a meaningful and a better life. So I thank you all for the listening. I
And,
don't know
and,
whether
and
it was like too
And
much.
thank you very
Uh,
much. No, no, absolutely perfect. Because this is the flavor
uh,
I wanted to have the students to have. Because, they are not going to remember all these things. They don't have to.
uh,
But until you have taken them through this amount of rigor, the things that, when we are referring to a pediatric neurologist, what are we expecting? When a pediatric neurologist is referring to us, what are they expecting, right? So this is the thing. Like, if there is a Canavan disease, we
uh,
would definitely like to have that child from very early on, because this child is not, we don't have the
hmm,
time to sort of orient the parents and then give them a quality of life for those 3 years or whatever time they have. But what we can give them must be given. This is called quality of life, and this is where we have to come in. What I wanted our students to understand is exactly what you have provided, is the common symptoms they see. There could be something very sinister behind it. Now they will understand what is the reason for the protocol that we follow. If that protocol
exactly.
is not followed, which we can discuss in detail later, maybe later today after your presentations, and whenever you need to leave, please don't hesitate. We thank you for your presentation, because
Um,
that's a real big discussion amongst ourselves, that, oh, I didn't know that urinary incontinence could be because of this also. They need to know that
yeah.
the diarrhea could have been actually something else.
Huh,
And these are the things like the migraine you talked about and all that.
huh.
So that's the fantastic thing that definitely is what I was looking for.
Thank
So
you, sir.
thank you
Thank
very
you.
much. I again hand over to Paulomi to have Dr. Arijit Chattopadhyay, who is one of those amazing doctors from a very long time, who have been supporting the multidisciplinary work, and has been continuously and steadily supporting our students every week whenever he can. I mean, it's almost 3 weeks a month he minimum delivers that lecture one to one with those students. I mean, I cannot think of a better committed doctor than somebody like Dr. Arijit Chattopadhyay. And this work is fantastic. I mean, if we then could bring Jashodhara into this thing, I mean, it's not possible for our students to regularly visit Jashodhara, but if we can have some sort of plan with Dr. Arijit Chattopadhyay together, so that this education series can be gradually improved to a meaningful level, where the care component to the patient becomes good. Like, even in Canavan disease, hospice, why can't we do that? We have all the skills there. Hyderabad is doing it. Why can't West Bengal do it? That's the objective we should now start thinking about, and start giving our children what children in the better world can take for granted. So without much ado, over to Paulomi Yogi to introduce the DOIN, and then sort of move forward.
Thank you so much, Dr. Bhattacharya, and a big thanks to Dr. Jashodhara Chaudhary for this insightful session. Moving forward, it is always a delight to introduce Dr. Arijit Chattopadhyay, a pediatric neurologist, DCH, MD, MRCP, FRCP, CHCC, ST, Pediatric Neurology, UK. He's a senior consultant pediatric neurologist, Apollo Multispeciality Hospital, Kolkata, and National Neurosciences Center, Kolkata. There are multiple indexed publications, there are multiple presentations, and without wasting much of our time, quickly I will take you through. Including in his several presentations, 2010 special mention for Dr. S.K. Ghotak Memorial Oration, IAP Coalfield Branch, 2010 Sri UN Mehta Oration, Yukon East, 2016 Srimati Rashmani Mukhopadhyay Memorial Oration, AOI West Bengal, 2018 Dr. Malavika Biswas Memorial Oration, Howrah Pedicon. Is the recipient of multiple awards and accolades, which includes V. Balagopal Raju's second prize in 1995 IIP Conference Indore, among his multiple membership to professional bodies like AOCN, ICNA, BPNA, IAP, IAP Neuro, IAN, IEA, IES, and ANEI. Welcome, Dr. Odijit Chattopadhyay. We have heard the first session from Dr. Joshudhara Chaudhary. Now we are eagerly waiting to hear your insight on pediatric leukodystrophies. The session is yours, sir.
And apologies for the technological hitch. Looks like the technological hitch continues.
Sir, can you share it? Arijit sir, can you share it? You are muted, sir. If you can respond, sir, unmute yourself.
So while we wait for him to join,
Sir is already there in the name of doctor who has joined. I think Arijit sir.
yes, I can see that he is joined, but I don't know whether his frame has frozen, because last frame was like that. So I've sent him a WhatsApp message.
Is sir's PPT present with you, Mr. Nitya? Because then you can present and sir can speak on that. Because I think
Yeah,
sir
I can
is
present
facing...
it. If sir, Arijit sir, you can send me through WhatsApp the PPT. I can present it. I think sir's voice is not coming.
Dear.
Then sir can present through phone also.
I think if sir can rejoin, I think there is some technical glitch. So if sir can rejoin, because his video and audio, both these are not working. So sir can, Dr. Chattopadhyay, if you can rejoin the meeting.
Yes, it would be better if you can rather leave and rejoin.
Meanwhile, from the attendees, I think if there is any question, because someone has raised the hand. So if there is any question in between, if we can take that question.
One question is there for Yashodhara. Just
okay.
Question is
which syndrome?
Agarwal.
Yeah. Now, Agarwal family has got this thing. This one, the vanishing white matter may be there, and also the limb girdle muscle dystrophy, where the child presents with different difficulty in walking and difficulty in getting up from squatting position. Like it is similar to the Duchenne, but it is not that. So the limb girdle muscle dystrophy. So those are the Agarwal family syndromes, and also some forms of scar, the spinocerebellar ataxia. So they have this name also. It may be one symptom may be called in different names, like.
So the story that I heard from Dr. Chattopadhyay was that they are from Mumbai. So this Agarwal family were seen by Dr. Brajesh Udani and few other sort of pediatric neurologists like Anita Hegde and all that. So when Van Knapp actually presented it and sort of published it, so this doctors were talking to Dr. Arijit that Dr. Arijit, look, we were writing it up, and we have written it up about we took about 3 years to write it up, which is why Van Knapp has gone ahead and published her series and got the name. And that's the story. I think it's very representative of what happens in India, that we don't do things on time.
Hmm.
That's such an important lesson for our students, because they have done quite nice researches, but they don't get these things published. Or right now we have a Hearts and Mind project about a finding in pediatric cardiology with children with special needs, which we believe is something that is we are seeing for the first time in the world. But I think we have been talking about it for more than a year, and we ourselves are sinner and with the same sin. I'm sure somebody will through grapevine the idea will go out and somebody will pick it up, and then somebody else's name will get through. So that story everybody needs to understand, that that instead of Van Nap, you should have been hearing that it should have been a Agarwal syndrome, if our doctors have really been able to write it up before Van Nap has, because probably Van Nap didn't really know about it earlier and might have had chat with our doctors, and then looked for it and found it and published it, which means the credit goes to Van Nap. Nothing bad has happened, but we missed out. That's something that you all need to pick up and learn from it. I think Dr. Rijit is probably having a major something mega issue. So if there is any comment you would like to make, Dr. Jashodhara, we can have that discussion in the meantime. Probably we'll have to leave before Dr. Chattopadhyay can join.
Opening the video.
Could sir
Network issue.
join?
No, join in. He is in the panel, no? I think in the name of doctor. One
Shall I
person has.
go? Shall I? Shall I?
That it is, huh?
Shall I leave so that you are not
No.
confused?
You have also joined as a doctor. Another person has joined as a doctor. So I don't know if it is Arijit sir.
No, that was Dr. Arijit's
If you can
frame.
check in the attendees list, there is
Yeah.
someone, sir's name is there. So if
No,
that
I
is sir, I
checked
don't
it.
know.
It is not there. I checked it. Acha,
I
Arijit,
have
now it is
sent.
there. Now it is there. Correct.
Yes, yes, it's there. So if
Now
you
that-
can just bring
got
him
it.
to the panel.
Yes, he has been brought in.
Send him the link.
No, he did. He does have a link. He joined before, but then I think it's a technical hitch that is going on. Okay. In the meantime, I think in the chat box, students can put questions if they want.
Yes, sir has been promoted. Now brought it in.
Got it.
Sir.
Yeah. Fantastic.
Yeah. Good evening, sir.
Yeah, good evening. So basically, I think there were two links. I linked into a link given by Shobita, and there was people there, and she introduced me, and then I couldn't open my. So there's some confusion about the Zoom passcode. Maybe two passcodes were being circulated, and I used one of them, which was not the actual one.
Apologies.
I did hear, I was able to hear most of Jashodhara's because I was there, but what the problem is that I couldn't unmute myself or show my, I couldn't see any picture that video on, video off, or mute, unmute. And neither could I share my screen. Neither could I say something. I was listening to everything that everybody else was saying. Anyways, shall I try and start my presentation?
Yes, yes, please.
Please,
You have
you
been
can do it.
introduced here as well.
Okay, let me try. So can you see my screen?
Yeah, you can.
Okay. So just stop me if anybody has a problem and I can understand that. So I was going to talk about approach to leukodystrophies in children. And I know the time is already past the hour that it was supposed to start.
Please don't worry, because we have kept the end time open just because we really wanted the learning fervor, the learning the point, the learning need to be fulfilled. As long as that happens, time we can manage. As long as you can manage, we are happy.
Okay, thank you.
Thank you.
So good evening, everyone. So I was going to talk about the approach to leukodystrophies in children. And the first thing we need to understand as students of medicine and also neurodevelopment is that there are two parts of the brain, the gray matter and the white matter, and the diseases also present in different ways. I'm trying to get a pointer option. Yeah. So as you can see here, pyramidal signs are early and prominent in white matter disorders, one of which is leukodystrophies that we were talking about. Ataxia is early and prominent, whereas dementia is early in gray matter disorders. Psychiatric symptoms are present more in gray matter disorders. Extrapyramidal symptoms are again more in gray matter disorders. As far as eye involvement is concerned, primary optic atrophy may be present in white matter disorders and retinal disease in gray matter disorders. Peripheral neuropathy is more likely to have a white matter association, and MRI will show subcortical white matter involvement in white matter disorders and cortical involvement in gray matter disorders. So these help us as clinicians in trying to differentiate whether it's a gray matter disorder or white matter disorder, but sometimes there is an overlap, especially in the late cases. So what is white matter disease? It is a loosely defined term that includes practically any disease process that has pathologic changes limited to or predominantly within the white matter of the brain. The pathology point of view, it can be primary demyelination, secondary demyelination, dysmyelination, and hypomyelination. In primary demyelinating diseases, there is characteristic loss of normally formed myelin with relatively preservation of axons. For example, in multiple sclerosis and neuromyelitis optica. Whereas in secondary demyelination, the demyelination associated with a known etiology or a systemic disorder, there is preferential destruction of white matter, both axons and myelin. And this can be due to infections like ADEM, PML, HIV, metabolic causes like pontine myelinolysis, vitamin B12 deficiency, as well as vascular related like aging, hypertension, and of course, trauma. In dysmyelinating or hypomyelinating leukodystrophies, what does dysmyelination mean? It means that there is a defective formation or maintenance of myelin, meaning it was defective in the first place. Whereas in demyelination, it was normal in the first place, but became abnormal later on. And in hypomyelination, it means that there is partial myelin, but never complete myelination. The process is delayed. Therefore, it's called hypomyelinating. So the difference between demyelinating and dysmyelinating is that pathological loss of myelin in demyelination, and in dysmyelination, myelin is not formed or is altered later on. Demyelination is associated with inflammation, mostly dysmyelination is not. You have asymmetrical involvement in demyelination, whereas dysmyelination has symmetrical involvement. The cause in demyelination is idiopathic or secondary, and the cause may be metabolic or unknown. And in demyelination, you have subcortical U fibers involved, and they are usually spared in dysmyelination. And this is just to show that this area is where you see the subcortical U fibers. And as you can see, this is a white matter disorder that is showing a hyperintensity in the white matter, but the subcortical U region is spared. But here we can see the increased signal right up to the end where there is a subcortical U fibers has been involved. So this is very important MRI finding and how to distinguish between the two. So in white matter disorders, again to summarize, you have demyelination, that means destruction of normal myelin. You have dysmyelination, where the formation of abnormal myelin. You have hypomyelination, which is disturbance of formation in myelin, and delayed myelination, which is another set of disorders where there is overall delay in the myelination process. Leucodystrophies are defined as a group of heritable disorders affecting the white matter or the central nervous system with or without peripheral nervous system involvement. These disorders have in common glial cell or myelin sheath abnormalities. And neuropathology is primarily characterized by the involvement of oligodendrocytes, astrocytes, and other non-neuronal cell types. For developmental specialists, this is an important slide. Even for doctors, pediatricians, when to suspect leukodystrophy. So here we are talking about some neuroregression, whereas where the milestones that were previously achieved have gone back again. So some common symptoms of leukodystrophy are either slow or regression of milestones. There is bilateral symmetrical signs and symptoms. There may be a family history of delay, regression, or early death. Early onset of visual failure, progressive ataxia, spasticity, and like Yashodhara was saying, in a lot of cases, behavioral changes and cognitive decline. Later on, or very uncommonly, they can present with seizures and myoclonus and tremors or other involvement of involuntary movements, because these are mainly associated gray matter involvement. So what would be the approach? The approach would be, number one, are there any useful symptoms? For example, head size. Some of the leukodystrophies, as has been discussed, has macrocephaly, meaning large head. Number two, is it primarily white matter, gray matter, or both? In white matter, you have spasticity, hyperreflexia, ataxia. In gray matter, you have seizures and dementia. And in deep gray matter, you have movement disorders. Is there involvement of other organs like liver, musculoskeletal, renal, eye, ear? And in a lot of these conditions, you do have associated other organ involvement. What is the MRI pattern? Anterior, posterior, or both? And you have seen some examples given by Dr. Yashodhara. Is the myelination lack or delayed? And again, MRS is a type of MR investigations. It's called MR spectroscopy. And you have different abnormal peaks like elevated NAA, lactate, or other peaks, and these all help. So like Yashodhara was saying, there are some adult onset leukodystrophies, but I'm not going to discuss that. We are going to discuss the childhood onset disorders, but you can see there is an overlap. And as she discussed, for example, in MLD and ALD, you may have a infantile onset, you may have a childhood onset, you also may have a juvenile onset, and you also may have an adult onset. So there are different types which may have an overlap between the childhood as well as adult onset. So this is a list of all the childhood onset leukodystrophies on the left and a lot of adult onset on the right. So here different names are there, and we are not going to concentrate on the names, but to understand that if you have a leukodystrophy at a particular age of onset, especially less than 1 year old, infantile, then you have a differential diagnosis. If you have a leukodystrophy that is early childhood between 1 to 5 years, then the differential diagnosis changes. And the same if you have for a juvenile and young adulthood, again, there will be different types of leukodystrophies that change or appear depending on the age. What are the clinical features in neonatal or infantile leukodystrophies? You may get an early axial hypotonia, you may get nystagmus or seizures, and late you will find spastic quadriparesis. Whereas in childhood leukodystrophies, again, there may be regression or delay of motor milestones with progressive upper motor neuron signs, with ataxia or dysarthria. And in adolescents or adults, you have more cognitive regression, psychiatric manifestation, behavioral abnormalities, motor manifestations are more subtle, and therefore a lot of these adults or adolescents, like Dr. Chaudhary was saying, present to the psychiatrists. The head size is important. There are certain leukodystrophies where there is macrocephaly. Examples are Alexander's, Canavans, type 1 glutaric aciduria, GM2 gangliocytosis, and Zellweger's. With macrocephaly and cysts seen on the imaging, you have the Van der Napp's disease, or and with macrocephaly and ataxia, you have the vanishing white matter disease. Again, in different types of leukodystrophies, there is a predominance of certain features like extrapyramidal in metachromatic leukodystrophy, nystagmus in Pelizaeus-Merzbacher and metachromatic leukodystrophy, early cerebellar in Pelizaeus-Merzbacher, early hypotonia in Canavans, absent deep tendon reflexes in metachromatic or adrenomyeloneuropathy and Krabbe's, and seizures in Krabbe's and neonatal adrenoleukodystrophy. And these actually help us to try and find out the possible type of leukodystrophy. I'm sure Dr. Chaudhary mentioned a lot about MRIs, but a good article on MRI-based approach to the diagnosis of white matters is this one that was published more than around 15 years ago now by Mario van der Napp and Raphael Schiffman, and a very sort of groundbreaking article at that point, where they showed the different sort of types of images where you actually get normal myelination at different ages. And to just let the beginners know, in an infant brain, there's a lot of things that appear as if the white matter is really sort of very prominent, but maybe normal. So you need the help of an expert neuroradiologist to take you through taking the age or corrected gestational age when you look at MRI pictures. What to look in an MRI? Presence or absence of hypomyelination, whether the white matter abnormalities are confluent or isolated and multifocal, whether it is predominantly localized in particular abnormalities, and whether they are cysts, contrast enhancements, and calcifications. So this is just an example of what a normal MRI may be compared to a hypomyelination and the demyelination. So you can see the difference in the T2 in the 3 and the T1 in the 3. So it's does definitely show you in the eye that there's a problem if you understand the basic MRI techniques. And Joshodhara was also mentioning there are certain patterns in white matter involvement, like this is the frontal, this is the front of the brain. So the frontal white matter involvement, this is the parieto-occipital, these are subcortical, periventricular again. This is diffuse because it is involving the whole brain. And here you can see cerebellar and cerebellar peduncle involvement. So for example, if you have a frontal white matter involvement, what is your differential diagnosis? They are as follows: hereditary diffuse leukoencephalopathy with sclerosis, Alexander's disease, adrenoleukodystrophy, and metachromatic leukodystrophy. In periventricular, you think about metachromatic leukodystrophy and Krabbe's disease. In parieto-occipital, adrenoleukodystrophy and Krabbe's. In diffuse involvement, you see Canovan's, megalencephalic leukodystrophy, and vanishing white matter disease. Cerebellar, again, Krabbe's, Alexander's, and adrenoleukodystrophy. And this is just to show that part of the brain, if there is an involvement, again, there may be a differential diagnosis. So it really needs a lot of input from a neuroradiologist to let you know what type of involvement there is and what may be the diagnosis. These are examples of different chemicals that may be abnormal in the different types of leukodystrophies, and therefore we sometimes have to use certain biochemical tests to see whether we can achieve the diagnosis. And this is a flow chart that experts use to sort of go through how to go through looking at an MRI brain and possibly looking at what type of leukodystrophy it could be. There are certain lab tests that help, although they are not diagnostic, but they help. Neurophysiology like NCV, evoke potentials like BERA-BEP, blood tests like VLCFA and lysozyme enzyme activities, urine organic acids, sometimes CSF. And previously we used to rely on biopsies like skin and nerve biopsies. But nowadays, with the availability of genetic studies like the whole exome sequencing, we are moving away from invasive tests and relying on just a peripheral blood test sample to give us a diagnosis. This is a study that shows the spectrum of leukodystrophies in children from North India that was published from All India Institute. And as you can see, there are wide varieties of leukodystrophies that are seen. Metachromatic leukodystrophy, as has been discussed, is most common type, autosomal recessive. There is a deficiency of enzyme aryl sulfatase, and it has 3 types. The age of onset can be between 1 to 2 years. NCB shows a marked slowing. There may be high protein content in CSF. The diagnosis is by deficiency of aryl sulfatase A activity in leukocytes or cultured skin fibroblasts. ARSA pseudodeficiency is seen, increased levels of urine sulfatide is also seen. And as I showed you earlier, you have typical pictures on the MRI. Adrenoleukodystrophy is another one which has raised levels of plasma VLCFA. There is mutations also found in the ABCD1 gene, Again, it has different phenotypes from childhood to adrenomyeloneuropathy to adrenal insufficiency type. And again, you see different sort of pictures on the MRI. Megalencephalic leukodystrophy with subcortical cysts, called the Van der Nap's disease, is remarkable for its relatively mild neurological signs and symptoms in the setting of very abnormal imaging study. Delayed milestones, macrocephaly, slow neurological deterioration with dysarthria and ataxia, seizures in some, and as Anjan was mentioning, in India, it's actually predominantly seen in the Agarwal community, and therefore in India we call it the Agarwal's leukodystrophy, where you see so many cysts that are seen with the white matter hyperintensity. And this is the article that was published after Van der Nap identified the particular condition, and this particular publication, this was not the original publication, beg your pardon, but the story is that Dr. Singhal, who is a very famous neurologist in Mumbai, and he must be in his 80s now, did find a lot of such leukodystrophy patients happening in a particular community, wasn't very sure about what was happening, and took time to sort of muster courage to make a publication. But by that time, Mario van der Nap had already made a publication, and therefore this type of leukodystrophy was called the Van der Nap's leukodystrophy. In Canavan's disease, you see a deficiency of an enzyme called aspartoacylase. Excessive accumulation of N-acetyl aspartic acid is seen. The onset may be very early on, with progressive macrocephaly, severe hypotonia, and persistent head lag. And most patients die in the first decade. You see specific peaks in the MRS, which gives a diagnosis. In Alexander's disease, you have macrocephaly with a large head and hydrocephalus with frontal lobe predilection. Again, it has different types. There is a mutation that has been found in GFAP. There is anterior to posterior progression with generalized gray and white matter atrophy, and the treatment is supportive. Again, very characteristic signs that are seen. In vanishing white matter, as Dr. Yashodhara was saying, there is chronic and progressive symptoms that are exacerbated by infection or head trauma. Mutations have been found. There is confluent and cystic degeneration of white matter, such that the whole of the brain has a CSF-like signal. You can have some lab screening. Prognosis is not very good. And basically, as it appears on successive or serial MRIs, the white matter actually slowly vanishes. So that is why it's called vanishing white matter. In Krabbe's disease, called globoid cell leukodystrophy, autosomal recessive, again, specific deficient enzymes. There is raised CSF protein. There may be motor nerve conduction delay and specific MRI changes. Medical management is the prevention of secondary complications in these children, such as infections, aspirations, tantamounting to preserving quality of life in leukodystrophy patients. This includes a prudent use of antibiotics and gastric tube placements. More than 70% of male ex-ALD patients have adrenocortical insufficiency. As the insufficiency can be latent, adrenocorticotrophic hormone levels need to be followed routinely during childhood. So this is all supportive therapy. There are certain treatable leukodystrophies, and this is an old slide, and Yashodhara showed you much more recent advancements. There have been advancements in treatment in bone marrow transplantation, if they can be done very early, and even in asymptomatic individuals. And other gene therapies that are coming up that haven't been mentioned in this old slide. But overall, there's a lot of research still going on, but in pre-symptomatic patients, something can be done, but most of the patients, there is no specific treatment or no specific cure in these children. I'll stop here. Thank you very much.
Fantastic and lucid as always, Dr. Ajit Chattopadhyay. That is why we wanted to have this session. And then Dr. Jashodhara has gone into the details. I just really wanted our students to have this flavor about what doctors do, but they don't necessarily have to do all those things, but they need to have an appreciation of what they do so that the team can support, because for them it is sometimes very difficult to conceptualize all this complicated stuff that we talk about, but they need to know that everything has a meaning of all the actions that doctors actually prescribe to the patients. So that is where they can support us in a big way, because as we know, the real work happens outside the doctor's door. And this is where a team of our multidisciplinary members can really make a huge difference to help parents who are completely misguided because of our social validations and community understandings, where we could really help them because somebody might need it. And I've just put it in the chat box that the all the more reason in today's day and age is because that because there are such promising treatments coming, if we can have them hanging on for another 5 years, live a bit happy with a quality of life, who knows, they may be lucky and come to a age where the definitive treatment, curative treatment can actually take place. So this is very important at this stage, and to join hands and work together about these sort of things, and maybe do some collaborative research about the things that I am talking about, like uh, the impact of out of the doctor's chamber events. So that those are very important things to research at this stage and to make a difference, because yeah, so we really need to sort of with people like Dr. Jashodhara, we could think of our setup and her setup, and we could really divide our students up and sort of have a conglomerate joined up research. We do it here, and then we can do it with the other doctors in other parts of India as well, because we are now well connected with very many doctors who often used to, I mean, some are abroad and some are here and there, and we just completed a huge training in Bailey's. They were there also, so I guess not everybody can do so many things together, but we must, because otherwise we will have Dr. Singhal's experience, and it's such a pity, because he might have had his name attached to it, and you have so nicely picked up, because these stories are the final things. There is so much science, but that science has to become a story, and we want to convert that into a positive story as much as possible. Because in my student days, I remember that what's the point of studying neurology, because at the end of the day we will say there is no treatment. But then after I have been abroad, and we have seen, since we have all been, and Dr. Ajit Chattopadhyay is actually has completion of his training, the CCT, the final sort of the ability that one can have from no other hospital than Great Ormond Street Hospital, and he also did his part of his training in Guy's Hospital. I mean, you cannot do better than that, and it shines through in his presentation to making it lucid, simple, catering to the audience, as well as not doing any injustice to the gravity of the subject. So it's a joy to watch all these things. And with Dr. Jashodhara, I think we have got really budding. She's quite established now, but quite a national and international soul who means what she says and she feels. And that is why we need to come together and sort of really make this journey for our children who could either have that future that because of Dr. Arijit's referral, the parents are now enjoying and the child is now booming, or the stories that we keep hearing that iska to kuch nahi hoga, and that should change because science is going surging ahead, like the artificial intelligence is taking over, and we need to partner it, we need to support it, we need to do that, and we can't do it alone. Doctors can't do it alone, and neither can the multidisciplinary team alone. It needs to be done together, and everybody valuing everybody's service, which we all are very sort of sensitive to, and we are very capable to do in doing so, as you must have noticed in all these deliberations, interactions, and the commitments that senior doctors actually show to your learning. So of course, I mean, it's a joy, Dr. Arijit Chattopadhyay, Dr. Jashodhara, to have you all. So anything that you would like to add to this effect, would love to hear those things.
Yeah, I think it's a learning process for all of us. Everybody doesn't know everything. There are people in the world who are full-time looking at leukodystrophy. So 7 days a week, 24 hours of their working day, like people like Mario van der Nap, and of course, so many other people like in her team. This is their full-time job. And then there are people who are doing research into this. And then there are people who are academic pediatric neurologists, and people like me who are clinical pediatric neurologists. And then there's developmental pediatricians who understand a lot of neurology. Then general pediatricians who have an interest and need to know definitely a significant amount for their clinical practice of neurology. And then there are all the other therapists of a multidisciplinary team who need to know a lot about neurodevelopment, which encompasses a lot of neurology, both the normal part as well as the abnormal part. And so you can see from how sort of step ladder pattern, from the top to the bottom, it is progressing. So the students also need to understand certain concepts. So what we are talking to you here, especially if you are a beginner, may sound really sort of, this is all going over the top of my head, but slowly sort of conceptualizing or understanding certain concepts of diseases, or even hearing certain new names, for example. This is all a learning curve for everybody. And even when you hear that particular name again in your sort of next time that you are seeing a patient or come across an article or are reading a letter or a note, then you say that, okay, I think I've heard this before. And there is so much of knowledge that you can actually get straight away if you really want to go ahead with that, including some basic knowledge from the internet, which of course always may not be 100% true, but then that gives you a starting, and then you look at for higher knowledge. So this really helps so that if you have an idea, then you can understand the what you call comorbidities. You can understand the prognosis in those particular children. And therefore, as a therapist, as a student, as a doctor, in whichever level you're working, even as a geneticist, you can guide the family, you can do the best for that child, you can look at all the other family members, and maybe even prevent another child from being born from the same condition if everything is done in the proper way, and trying to do the best for the child who has been involved, and also supporting, protecting the family and the parents. So it's a learning curve, and we are all small little sort of parts of a big jigsaw in the treatment of any child, and we should uh, definitely do our part so that once we fit in the jigsaw, we have a complete picture of treatment. That is the concepts that we want to get across to the students.
Thank you. Fantastic. Fantastic. Dr. Jashodhara, if you want to say something at this point regarding all these things, it would be nice if you are there. I know Dr. Jashodhara wanted to leave early, but because it looks like somebody is still logged in.
I don't think Madam is there in the
Right. Plan. No problem. No problem. I think we have a master plan. She has another program to go to, so that's why she had to leave. She has told me beforehand. So when there was this technical hitch, that is why we got Dr. Jashodhara first, because the way your presentation is sort of done, it would have been a nice beginning, but
Yes.
incidentally it worked out very well. Once they have got their mind messed, you kind of put them in order very nicely and sweetly. So what I would really like and to propose is that, please think over how we can include Dr. Jashodhara to a part of this learning, so that, your work could also be sort of, we are stretching you, we know that, and we are very thankful for that. But, we could then sort of, we need the right kind of person to do this. We don't want these young people to have a wrong message going in their head. So we need you, we can welcome Dr. Jashodhara, but you will have to kind of guide us and sort of, hold hand into how to do it and how much she should and where and how. So we will get in touch with you with those questions later. Please think through, so that, what they are having over there in UK, USA, Canada, that, there is somebody who is doing neurological research, who is doing a bit of administration on that. Somebody is therapy, somebody is doctor. We should have that aspiration, and we can start from here. I mean, if there is no start, it's never going to happen. So we would like to make this start, and so that, and then let this very young very dynamic group of, even if there are 12 of them, then that's a fantastic 12. We could really make a start with them and make that happen. I mean, 12 is more than what Swami Vivekananda expected and never got, if we remember his lamentations. So I think we have got more than that. We have got a better time, we have got all the solutions coming our way. So yeah, we need to put our best foot forward. So thank you very much. Follow me.
Thank you so much. Thank you, Dr. Bhattacharya. Thanks to Dr. Jashodhara Chaudhuri and Dr. Arijit Chattopadhyay. I think we have this was broadcasted on YouTube Live. So we have the YouTube link, and if we visit the page, official YouTube page of Shield Connect, then we can also watch this video. And we are sorry for the technical glitch, but that sometimes happen in this online setup. We're trying to get this infrastructure more robust, so that in future we don't face this kind of problems. A big thanks to Shield Connect for organizing this, and also to our participants who have joined us on a Sunday afternoon. It was very good to see all of you here. And we are soon going to come back with similar webinars for knowledge sharing. And also we would like to say that the end objective is same, that how multidisciplinary therapies are bringing the changes in the Indian treatment scenario, and how we can contribute to that from our own individual capabilities, and finally, as a collective goal, we can reach together at that place. So with all this, thanks a lot. Thank you, the Shield Connect team, for coordinating. Thank you. We'll take a leave. Is there any question?
And thank you, Paulomi.
Thank you, sir. Thank you. Most welcome.
Thank you,
Uh,
Polomi madam. Thank you,
sir.
Anjan sir, Arjit sir, and Yoshikura madam. Thank you for making us associate for this wonderful program.
Thank you.
Thank you for having me.
Good night, everyone.
Good evening. Good evening.
Bye.